Well, I am Dr. Vinod Kumar. My field of interest is old age care, that is geriatric, as well as diabetology. And I am speaking today about a subject which involves both these fields. And I would just start by sharing my slide on the screen, and then we begin. So here we are. I'll just put them on the slideshow. So I would be talking about geriatric syndrome, which are the conditions in elderly that do not fit into any specific disease. And most of these syndromes complicate the care of older diabetics by interfering with their self managing abilities in day to day life. There are 7 geriatric syndromes that will be talked about in this video. All begin with the alphabet I. First is impaired intellect or dementia, immobility or frailty, inappropriate medicines, that is polypharmacy, impaired vision and hearing, imbalance that can lead to falls and fractures, incontinence, which can lead to urinary problems, patient being unable to hold the urine, and sleep disorders, particularly the sleep deprivation, what we call as insomnia. First geriatric syndrome is dementia. It is an umbrella term used to describe a set of symptoms that can include changes in memory. There be difficulty in perceiving, difficulty in reasoning out, and lower attention and concentration power. Thinking is compromised. Judgment is not easy to take, and they have difficulty about communication as language. And these impairments should be severe enough to be called as dementia. They should interfere with person's ability in day-to-day functioning. Diabetes and its various complications that are enlisted here are themselves risk factors for dementia. What happens if there is a dementia and diabetes coexisting in the same elderly individual? If a diabetic patient develops dementia, he can forget taking medicine or forget that he has already taken. There will be risk of taking twice. He might forget taking meals leading to hypoglycemia, or he might forget taking liquids leading to dehydration. He might be undecided in adjusting the insulin dose and may consequently take a wrong dose leading to hypo or hyperglycemia. He may forget how to do an injection that he was able to do earlier, and he may be no longer able to identify his medicine. If the dementia patient develops diabetes, he may be not able to find toilet in the house and unable to hold the urine, and he runs into the risk of incontinence. He may fall in the night while looking for toilet and get himself injured or even get fractured. If there is too much of high blood sugar, hyperglycemia, he can face dehydration, which can lead to confusion. And finally, he may be not able to put his distress in words, and he may start shouting or crying. So therefore, anybody who is 70 years old, he is a diabetic particularly, he should be screened for dementia by Hindi mental status examination or mini COG test. The second geriatric syndrome is frailty. The warning signs are weakness, slow walking speed, low level of physical activity, fatigue or exhaustion, and unintentional weight loss. Frailty on the left side is the diagram shows diabetic patients over the years, they lose their muscle mass, thereby they get functionally limited, and finally, to complete the spectrum of frailty, they may become disabled. Frailty is a state of limited reserve which is linked to inferior treatment outcomes and higher risk of hypoglycemia. It is important to rule out frailty in all those who are aged more than 70 years by validated instruments. Anti-hyperglycemic or anti-diabetic agents which cause weight loss should not be given to diabetics at all, and frailty is also associated with the risk of hypoglycemia and fracture. The screening method to detect frailty is by mobility testing, that is, he's unable to walk 4 meters in 6 seconds. By strength testing, that is, a male person has a grip strength less than 12 kilogram and a female less than 7 kilogram. Nutrition, if it is compromised, that is judged by finding out if a person has lost 4 kilogram or more of his body weight in the last 1 year. Energy is by self-reported exhaustion, at least for 3 to 4 days in a week, and physical activity means zero weight bearing like climbing stairs or spending more than 6 hours in sitting and lying outside his sleeping hours. 1 point is assigned for each of these positive points. Frailty means 3 or more points. Pre-frail means 1 or 2 points. And if there is no point which is positive, we can label a person comfortably as non-frail or robust. Polypharmacy is the third geriatric syndrome. This could be meaning taking 5 to 9 drugs. And if a person is taking 10 plus drugs, we call it heightened polypharmacy. Polypharmacy warning signs could be low blood sugar, orthostatic hypotension, and syncope. There could be lethargy, confusion, somnolence, or extrapyramidal symptom. Patient may also sometimes have a dry mouth, diarrhea, constipation, or bloating. Or patient may have high pulse rate, congestive heart failure, or edema. Polypharmacy prevalence is very high in diabetic patients who are elderly. It can be as much as 60% of these patients taking a lot of drugs. Polypharmacy impacts adverse health outcomes among older diabetics, especially. They increase the risk of diabetic control and hypoglycemia, and they also increase the risk of falls, hospitalization, and death. The color diagram shows blue bars indicating non-diabetic elderly, the orange bar indicating the diabetic elderly, and the green bar indicating those diabetic elderly in whom anti-hyperglycemic or diabetic drugs have been not counted. So you find on the left side, 35.4% of those who are not diabetic, only 35% are taking no drug at all, zero drug. But if they are diabetic, only 4% of diabetics are such who do not require any drug. Coming to the third part of the graph, you will find that 14% of non-elderly, non-diabetic elderly are taking 5 to 9 drugs, only 14.9%. But as many as 50.2% of those elderly who are diabetic, they may be taking 5 to 9 drugs. And when you come to 10 plus drugs, you will find that those who are non-diabetic, only 1.7% have a possibility of not taking 10 plus drugs. But as many as 10% of diabetics may be taking 10 plus drugs. So this is the scenario. And then we come to the next geriatric syndrome, that is hearing or vision impairment. Prevalence of vision loss as well as hearing loss is much more in elderly people and more so in those who are elderly as well as diabetic. And general impact of these impairments will be felt by difficulty in self-management of day-to-day life, including the management of disease. They may get slowly disconnected from the society. They may feel isolated or even feel lonely. And because of the vision loss or hearing loss, they may be vulnerable to falls. This shows the impact of hearing and vision loss on three conditions. One is myocardial infarction on the left side, the stroke in the middle, and all-cause mortality on the right. The blue line, the topmost line, indicates patients who have both vision and hearing impairment, while the bottom line, which is black line, indicates those diabetic elderly who do not have any of these impairments. And you will find that the incidence probability of myocardial infarction, stroke, and all-cause mortality is highest in next 10 years in patients who have both vision and hearing impairment, and it is the least in patients who do not have any of these impairments. This is the next geriatric syndrome, that is imbalance leading to falls and fractures. Recurrent falls means 2 or more falls in the past 6 months. Again, they are more common in elderly diabetic compared to non-diabetic elderly people, and many factors which can predispose to falls and fractures are polypharmacy, cognitive impairment, insulin therapy, sarcopenia or muscle loss, frailty, and neuropathy. Elderly diabetics are more prone to fragility fractures also. By that I mean contracting a fracture when falling from his own standing height or even less than that height. And the predisposing factors for this also include osteoporosis, vitamin D deficiency, associated diseases like comorbidities, insulin usage, diabetic neuropathy, and retinopathy. Delayed healing, delayed healing will be an impact. Self-managing difficulty again, cannot do exercise or physical activity limitation, greater need of medical care, and sometimes anti-diabetic drugs have to be changed. This is the next geriatric syndrome, last but one, urinary incontinence. Older men, particularly older women, suffer from urinary incontinence more if they are diabetic compared to those if they are not diabetic. Obesity is associated more with incontinence. This results in negative influence on quality of life, health, self-perception, physical functioning, general mental health. And it may be noted because of the gender difference, this complaint is often less reported to healthcare providers by elderly women. Sleep disorders is the last geriatric syndrome. Many older people are unable to sleep properly, and among the diabetic patients, a 50 to 70% prevalence. Predisposing factors include old age, comorbidities, polypharmacy, nocturnal hypoglycemia, neuropathy, duration of diabetes, insulin use, and insulin resistance related obesity. Sleep deprivation can cause poorer glycemic control, risk of developing chronic diabetic complications, increases diabetic stress, anxiety, and depression, can lead to falls and injuries. Both too short and too long sleep increase the risk of cardiovascular events and death. And it may be noted that female diabetics are more prone to sleep disorder than their male counterparts, and the impact is greater in them. So take-home message is that geriatric syndromes are more common in elderly diabetics than elderly non-diabetics. Polypharmacy, problems of sleep, vision, and hearing are common but underdiagnosed and followed in frequency order by incontinence, falls, cognitive dysfunction, and frailty. Geriatric syndromes impact diabetes by compromising with diabetic control, self-management, health-related quality of life, and hypoglycemia with its consequences like neurocognitive and cardiovascular morbidity, falls, and fracture. Thirdly, geriatric syndromes can contribute to one another in the same patient and render his life further difficult. Examples are frailty, cognitive dysfunction, insomnia, polypharmacy, and lower vision, all contributing to falls, while dementia contributes to incontinence also, and polypharmacy contributes to sleep problems also. So finally, geriatric syndrome focused recommendation are the need of the hour and should become the part of the standard of care. With this, thank you very much for watching this video. Thank you.